Thank you so much for a kind introduction. I want to say hello again and thank you to my Indian friends, Dr. Archana as well, especially. It's great to come back to India to see every year the progress. Archana, I know what you mean when you say that years ago we never had any mention of pediatric diabetes in these meetings, and now we will move on. I, I I think it's very, very important to remember that in pediatric diabetes, it's actually a very big spectrum from pre-diabetes, type 1 diabetes. Many people with type 1 diabetes actually have features of type 2 diabetes, which will be touched on by our next speaker. And I am talking about celiac disease and gluten intolerance. And some people also say that studies have shown celiac disease and gluten intolerance may precede and precipitate diabetes, type 1 diabetes. Um, and it's also very important for preservation of beta cells. So in the pediatric space, much of what we tell each other and study with each other actually has got relevance and sort of feeds back into the system. But let me just go on first. So my disclosures, I have no commercial disclosures here. Now, celiac disease when I was in medical school was something that we never needed to bother about. You know, the textbook said this was actually a white man's disease. You shouldn't see it in Asia. But we now realize that perhaps in Asia, more than anywhere else, celiac disease and gluten intolerance is very, very important and maybe double the prevalence of what you see in Europe. So firstly, it's a systemic disease triggered by ingesting gluten, which is merely a protein in wheat, rye, and barley. It is frequently asymptomatic in some ways, but may present with gastrointestinal symptoms or with extra-intestinal features like a systemic illness. It can also present with poor sleep, neurological, behavioral, and learning problems. And in the pediatric endocrine space, can be seen in 20 to 60% of children attending a short stature clinic in the West. It is very important for us to remember that nowadays a classical presentation of celiac disease with mainly GI symptoms is actually in a minority. Only 27% of celiac disease patients in 2024 would be presenting with classical GI symptoms. 20% may have no apparent symptoms, and half of the patients might present with unexplained anemia, unexplained abnormal liver function, or some bone issues, or some other funny things. And non-gastrointestinal signs in pediatrics would include delayed puberty, short stature, iron deficiency anemia, recurrent fetal loss, osteoporosis, chronic fatigue, recurrent mouth ulcers, missing teeth, or funny rashes that don't go away or get worse when you eat certain foods. Even if it's not diagnosed, if you are seropositive for celiac disease, long-term studies have shown that there is an increase in mortality, in cardiovascular disease, in autoimmune disease, and in cancer risk. This was a study from Denmark. How about our diabetic patients? Well, celiac disease may seem to be asymptomatic in diabetes patients. In adults in the West, they say it presents with actually lower HbA1c and lower insulin requirements. But while it can present with lower HbA1c and hypoglycemia, I think that in Asia, it can often present as hyperglycemia, as post-meal spikes, or as prolonged hyperglycemia following ingestion of gluten-containing foods. It can present with recurrent abdominal pain and hyperglycemia, or headaches and hyperglycemia. It can also present as Mauryak syndrome, severe poor growth, and sometimes with insulin edema. So the clinical features of celiac disease in type 1 diabetes patients may be subtle, atypical, or may be completely lacking. But if you have a gluten-free diet in an identified type 1 diabetes patients, often the blood glucose control improves, and it has a positive impact on other biochemical parameters and other growth parameters. So Should we screen everybody? Can technology help? Is there further need for us to do this? Well, apparently, celiac disease is also an independent risk factor for retinopathy and nephropathy in patients with type 1 diabetes. If you have celiac disease, retinopathy and nephropathy appear 10 years earlier, everything else being controlled for. So is it really more prevalent? Well, in studies from the West, if you take the background risk in Caucasians for celiac disease to be 1%, the lifetime risk of celiac disease in type 1 diabetes is 8 to 10 times more. If you have Hashimoto's, it's 4 to 15 times more, right? And think about it. Hashimoto's appears in 20 to 40% of type 1 diabetics. Autoimmune liver disease, unexplained liver function, abnormalities, and so on, and relatives of diabetes patients, yes, there's an increased risk. So in summary, the autoimmune disease, thyroid disease risk is between 17 to 30% of patients with type 1 diabetes. Some papers would say even as high as 40%. But a patient with autoimmune thyroid disease is 4 to 15 times more likely to have celiac disease than the normal population. Celiac disease itself, serology, is positive in 1 in 4 patients with diabetes, depending on the test used. In my series, it can be as high as 40%. Biopsy positive celiac disease is seen in 6 to 8 to 15% of patients with type 1 diabetes. And we'll talk a little bit more about biopsy positivity later. But often many of these patients are asymptomatic or have symptoms overlooked by their doctors. And one very important symptom in our pediatric patients is glycemic variability or brittle diabetes. This is a disease that has been getting more and more prevalent. In the last 10, 20 years in the West, it's been going up. Many years ago, we used to think that it wasn't in our part of the world, but the paper on the right was a paper from All India Institute of Medical Sciences, and it says that about the prevalence in India is somewhere in the region of about 1 to 1.5%. It's 2% in young adults in China, and about 1.25% of young adults in Malaysia. Something else has come up fairly recently. You know that we've got the forever chemicals, the PFAS. There was a study from Langone University in New York where they found that if you had substances similar to the non-stick Teflon pans or even pesticides like DDT, DDE in your bloodstream, you would have a much higher risk of celiac disease. And if you're a male, if you had residues of fire retardant chemicals in your bloodstream, you would have also increased risk of celiac disease. This level of risk far outweighs any of the conventional risk factors we talked about, including the genetic risk factors. And guess what? In India, these chemicals are prevalent everywhere. It is in water, it is in breast milk, it is in fish, it is in vegetables, it is even in snow in the Himalayas, in the hill regions, and it is in your swamps, your mangrove swamps. It is up to 16 times the permitted level in breast milk samples from 3 parts of India. Yes. So what do the guidelines in the West say about screening? Yes, they say, well, must screen everybody. But, screening for celiac disease is expensive. Do we screen everybody? Do we follow the guidelines and screen every few years? I think you should screen when you have unexplained spikes, when you have a clinical picture. That's why I talk so much about the clinical picture. The other thing is that there's a gold standard of having to use a biopsy. But even in the West, people are moving away from the biopsy, because biopsies were done in the days before there was such a thing as blood tests. In some Indian studies, they found that where there is seropositivity, which is about 10-15% of type 1 diabetics, only a minority of these patients would have villus atrophy. I think it's not because they don't have celiac disease, but you're picking them up earlier, and also because the amount of gluten that you eat in an Asian diet may not be as high as in the West. The profile of patients in Asia is also different. They may present more with growth problems in addition to diabetes-specific manifestation. But the important thing is all these manifestations get much better if you actually pick them up and treat them. Should you use TTG-IgA, which is often written about in the West? A recent paper that comes from the West itself suggests otherwise. And they say that there's a verification bias in TTG-IgA. If you account for the bias, in a verification bias, TTG-IgA is only as good as a toss of a coin, 50%. So what should you use otherwise? We should perhaps be using the other tests, TTG-IgG, DGP-IgA, DGP-IgG. I myself recommend the 4-test panel. This is the 4 tests. I personally use the ones from the Euroimmune company because they have at least 3 of them from the Euroimmune company because they have a very wide gray zone. But I'm not speaking on behalf of any company. I would just say choose a test that gives you results, measurable results in the gray zone between positivity and negativity. Because in the West, the positivity was based on people eating gluten 21 times a week. And very often in Southeast Asia, we only eat gluten 5-10 times a week. In my own series of patients, which I did about 100 patients, here's some data from 70 of them. A lot of the patients who are from Asia would be positive for tests other than TTG-IgA. And surprisingly, the Asians are more likely to be having positivity to celiac disease tests than the Caucasians. So for example, in this study, you can see that the Chinese actually have 40% seropositivity compared to the West, right? The other thing is gluten intolerance. Gluten intolerance actually is considered a milder form of celiac disease. But if you do long-term studies, many of the people with intermediate serology actually will end up with celiac disease serology. More importantly, the clinical picture is not distinguishable from celiac disease. They have glycemic hypervariability. I will talk about it more in my talk in 2 days' time. Many of these patients actually with gluten intolerance have symptoms overlapping with type 1 diabetes, with celiac disease, sorry. So we should actually ask ourselves, what are we screening for? A strict definition for epidemiological reporting purposes, or to identify patients in whom a change in diet will make a difference in the quality of life and diabetes care. The other thing is, in many places, we only test for TSH when looking for thyroid autoimmunity. That I think is not quite right. We should, where possible, do TPO antibody and TG antibody because those people with TPO antibody and TG antibody positivity are also more likely to be celiac disease positive. And those who have antibody negativity but abnormal thyroid function are also more likely to have a variant of thyroid dysfunction caused by celiac disease. With this, I stop here. Thank you very much.